it's that old superhero model, you know. You knew the job was dangerous when you took it. But Jonathan, what are the advantages, as you see it as a clinician, of these new emerging therapies?
Yeah. The key thing for almost all of these new emerging treatments is really safety. And right now, certainly the efficacy, absolutely, and it's that balance between the safety and the efficacy. You know, we have, you know, on the topical side, topical steroids, which technically are effective, but we're limited in how long we can use it, and that ultimately leads to poor real-world, you know, effectiveness. When you think about systemic agents out there, our options are systemic steroids, cyclosporin, methotrexate, azathioprine. These are scary drugs.
I was going to say, as an intern is sitting here listening to those names, I'm beginning to
Right.
shake, and I'm not paying for them.
Right.
And none of those drugs are approved.
Exactly. None of them are
They're all
FDA
off-label,
approved.
are they?
Exactly. All off-label. And they come with some hefty baggage. So, you know, the issue is for patients who do get treated with these drugs, they get a lot of iatrogenic complications because of it. And for the patients, for many, they're just not being treated with them at all, and they're just miserable because there's this fear and reluctance to using them.
Okay, but let's come back now to these two new drugs that are creeping up,
Right. So
that are on the horizon. What are their advantages in your view?
Right. So the crisaborole on the topical side is a nonsteroidal agent that, at least based on the data that we've seen so far, looks like it has some pretty good efficacy. So it may rival something the equivalent of a mid-potency topical steroid, but has that advantage that you could use it longer term in patients without worrying about those safety issues.
Okay.
On the flip side, when you think about dupilumab, well, for starters, the efficacy is really the best we've ever seen so far. So it may be that with this drug we get better results than with anything that we even have right now. But on top of that, it's the ability to keep patients on it longer term. You know, the current standard right now with, let's say, steroids would be give them a 5-day course of steroids. They may do well while they're on it, but then they rebound, or they get this, you know, severe flare down the road. And so here, for patients who are chronic, who have persistent disease, we have at least the safety behind it and the efficacy data to suggest that we could keep them on it longer term.
Well, I'm sorry, go ahead.
But I
Cheryl.
have a question, though, going back to the solo studies. Investigators' global assessment, is that something that you use in your practice?
No. And in fact, the investigator global assessment is very challenging. It's actually a fascinating systematic review that was just published I think, the past couple of months that shows there's about 47 different investigator global assessments out there, and they're not all the same. This is a global measure that the FDA likes. It's not one that really has any validity behind it. Our preferred assessments, I think we'll talk about that a little later, are ones that also are not really used clinically, but are ones that at least have a little more methodologic validity around it, like this EASI score, the EASY score, or the Scoring Atopic Dermatitis, or SCORAD. So, you know, using this IGA is a little tricky from a clinical standpoint, and there's going to be a little bit of a disconnect between the trial outcomes versus what we would probably use in the real world.
Okay, now, I think I know the answer to this because we've been talking about it, but are the payers really paying attention? I know you are, but are all payers as attuned to it as you are? Or is this going to come as a big surprise very soon? And what about the specialty pharmacies? Because they're going to be the pharmacies providing these drugs. Are they aware?
Payers will be aware of this as far as the pipeline, for sure.
What about the specialty pharmacies? What do you think?
Absolutely. In fact,
I mean, are they aware now? If I were to call a specialty pharmacy and say, about these new
yes,
drugs, what would they tell me?
So payers are aware of that. They're looking at cost. Specialty pharmacies are monitoring this for our patients and for education purposes.
But what Jonathan said, I think, to me personally, is one of the top 3 or 4 issues right now with this, is we don't have objective measures. So if they're not using IGA or EASI, and it's hard for us to have a benefit discussion with a physician or provider about, is this drug working, when to start it, when to stop it, when all we're getting back is the patient feels better.
Well, if the patient feels better, I mean,
well then,
what's wrong with that? But again, you've got to have, what you're looking for is a metric, right?
and if it's free, fantastic. But if there's a dollar associated with that, that's why I have to have that conversation.
Okay.
And you know, the issue with the, let's say for example, dupilumab, which I think is going to be the more costly, or the systemic agents in general will be the more costly ones. You know, these are not meant to replace a topical steroid or any topical agent for that matter. They're really designed for those patients who are refractory or somehow contraindicated to the topical agents out there. And that's going to be, you know, a much tinier segment of the population, but those are also the ones who they've already expended, they've already gone through all the generic cheap stuff that you're comfortable with, and there's nothing left.
I don't disagree. I think at some point we will get there where, you know, I think the initial utilization management will be step therapy. You've tried these other agents, or you have a contraindication. That's just to be expected. And then that may be loosened up over time as we get more comfortable. But that's,
Other disease states have gone that route, right?
Exactly.
Step, 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 and then wait a minute.
But
we don't need to step
you know,
anymore.
and to your point, if the drug's not working, you would think, because of the cost and the member out of pocket and everything else, that these patients would stop taking the drug. But again, we still want, from a payer perspective, in an ideal world, we would still love it to have some consensus around when do you start, when do you stop, who's the appropriate patient, what is the objective measure for us if this drug's working.
Well, I've been listening to you, and something that crossed my mind as an internist, not as a dermatologist, is you're going to wait for a flare and then use these drugs. But if this is a chronic drug, a chronic disease, and it's always there, whether it's simmering along or just bursting out, wouldn't it be better to suppress? And if these drugs are useful long-term, why not just keep somebody on it?
And so, you know, we try that in dermatology all the time. In general, you know, working on everything we can prevention-wise that wouldn't require pharmacology, you know, moisturizer, avoiding triggers, things like that. So we're doing the best we can with this already, but sometimes even with the best practices, you can't fully avoid these flares. There is definitely a big shift in the field to try to work on prevention of flares. And we do that now even using some of the topical steroids where you could use it a couple of times a week on clear skin to prevent flares from happening. But it's sometimes just not enough, and you fall right back into that trap where patients are using topical steroids every day and are going to run into the side effect issues. You know, when it comes to the systemic therapies, it's very hard to use anything we have right now for prevention of flare-ups because that would require keeping them on it for extended periods of time. and then there's the safety issue that just comes up almost immediately.
So that brings to mind